unpack our first condition today, Sjögren syndrome.
Okay, Sjögren syndrome. It's an autoimmune type IV hypersensitivity reaction, which basically means your own immune system mistakenly attacks and damages your exocrine glands.
So wait, break that down. Your body's defense system, the part that usually fights off infections, actually turns on itself and starts attacking the glands that produce moisture, like your tear and saliva glands.
Exactly. It's a delayed reaction,
Yeah.
type IV. Specific immune cells, lymphocytes, are the primary culprits in causing that damage.
Wow, okay. We actually got an email that really brought this to life. Here it is. I remember when my mouth started feeling like sandpaper and my eyes felt gritty, like there was always sand in them. I'd wake up with my tongue stuck to the roof of my mouth. My doctor explained this is my immune system attacking my tear and saliva glands, which they called keratoconjunctivitis, sicca for the eyes, and xerostomia for the mouth. It explained why even blinking felt like a chore and why I couldn't enjoy food. They checked for a few things like anti-nuclear antibodies and rheumatoid factor, but the key was finding specific immune markers called anti-RASA and anti-SLE antibodies. Finally, a diagnosis. So, you can just feel that relentless dryness from their description, can't you?
Absolutely. And what's truly fascinating here is how that very specific immune attack on the exocrine glands leads directly to those classic symptoms: dry eyes, dry mouth. Recognizing that pattern that your own immune system can be, well, an enemy within is key to understanding this. And those specific antibodies, the anti-Ro and anti-Light, they're crucial diagnostic clues.
From one autoimmune battle to another, let's talk about systemic lupus erythematosus, or SLE.
Right, SLE. It's predominantly a type III hypersensitivity reaction. Think of it as a problem where immune complexes, combinations of antibodies and antigens, basically immune debris, aren't cleared properly by the body, so they circulate and deposit in various tissues, causing widespread inflammation. Some of its blood-related issues, though, are actually a type II hypersensitivity reaction, where antibodies directly target and destroy specific cells.
So the body's cleanup crew isn't doing its job right, and this immune debris just floats around, settling in different places and causing trouble. That sounds incredibly unpredictable.
It truly is. That's one of the hallmarks of lupus.
We had a listener share their story. I was in my mid-20s when it started. First, the joint pain, then this butterfly-shaped rash across my face after sun exposure, what they called a malar rash. I felt so tired all the time, and my fingers would turn white and numb in the cold, which my doctor diagnosed as Raynaud phenomenon. It was overwhelming, but when they ran blood tests, finding things like anti-nuclear antibody or ANA, and then more specific ones like anti-double-stranded DNA or anti-dsDNA and anti-Smith or anti-ESM antibodies, there was finally a name for everything. It's a daily battle because it affects so many different parts of my body. It really sounds like a constant fight.
It does. And if we connect this to the bigger picture, SLE's diverse presentation, like that malar rash and the joint pain, really emphasizes how those circulating immune complexes can impact multiple organ systems: joints, skin, kidneys, brain. It can be anywhere. Those specific antibodies like ANA, anti-dsDNA, and anti-natism are absolutely central to its diagnosis. It's a master of disguise, really. But those antibody patterns often give it away.
Okay, let's shift gears to a medical emergency that demands rapid attention. Blindness in giant cell arteritis, also known as temporal arteritis.
Yes, this one is serious. The underlying mechanism is ophthalmic artery occlusion. That just means the main artery supplying blood to the eye gets blocked, usually by inflammation.
Blocked, okay. And this next story is a really terrifying experience that highlights why quick action is so vital. A listener recounted, I woke up one morning and my vision in my right eye was just gone, like a curtain had fallen, completely dark. I'd been having these terrible throbbing headaches around my temples for weeks, and my jaw hurt when I chewed. Simple things like eating. My doctor immediately suspected temporal arteritis, explaining that the blood vessels, particularly the one to my eye, could become inflamed and blocked. They started me on high-dose steroids right away, even before confirming with a biopsy, because my blood test showed markedly elevated ESR and CRP markers of inflammation, and I was over 50. But it was too late for that eye, vision gone. The doctor said if I hadn't come in immediately, I could have easily lost vision in my other eye, too. That story just underscores why rapid treatment is absolutely crucial.
It's a stark reminder, isn't it? Some symptoms, like a new persistent headache in an older adult, especially with jaw pain or visual changes, they aren't just an inconvenience. They can be a ticking clock towards irreversible damage. That ophthalmic artery occlusion can lead to permanent blindness, sometimes very quickly. Recognizing those clues, being over 50, the specific headache, the jaw claudication, elevated inflammatory markers like ESR and CRP, it demands immediate steroid initiation. You start treatment before the biopsy confirms the granulomatous inflammation in the vessel wall. It's a true medical emergency where every minute counts.
Next up, a condition where communication breaks down at the muscle level, myasthenia gravis.
Yes, myasthenia gravis. This is an autoimmune condition where your body produces autoantibodies that specifically attack the postsynaptic nicotinic acetylcholine receptors.
Okay, whoa, that's a mouthful. How does that translate to what someone actually experiences? Like, what does that feel like?
All right, let's simplify. Think of it like this. Acetylcholine is a chemical messenger. Nerves release it to tell muscles to contract, to move. When it gets to the muscle, it needs to connect with specific receptors on the muscle's surface, like a key fitting into a lock. In myasthenia gravis, the body creates antibodies that essentially gum up those locks, the receptors, so it's much harder for the acetylcholine signal to get through.
Ah, okay, so the signal is sent, but the muscle just isn't hearing it properly because the receiving end is blocked.
Exactly. The communication is disrupted at the muscle side.
Got it. A listener sent this in, and it sounds spot on. It started subtly. My eyelid would droop a little by the end of the day, and then I'd start seeing double. Chewing my food felt like an Olympic sport. It was so exhausting, and sometimes my voice would just fade out mid-sentence. One terrifying night, I really struggled to breathe. That was the scariest part. Doctors suspected something with my muscles and did a test where they injected medicine, edrophonium, I think, and for a few glorious minutes, my eyelids lifted and I could see clearly. They later confirmed it was myasthenia gravis, where my body attacks those receptors on my muscles. The unpredictable weakness is the hardest part, especially, when it affects breathing.
That description is perfect. What's fascinating here is that fluctuating muscle weakness, the kind that gets worse with use and actually improves with rest, is absolutely classic for MG. Those drooping eyelids or eptosis and double vision or diplopia are very often the very first symptoms people notice. And here's a crucial point to remember, a real exam parole. Myasthenia gravis has a strong association with problems in the thymus gland, particularly a tumor called a thymoma. Checking for that is key.
Okay, building on that, let's look at another muscle weakening condition, but one with a critical difference. Lambert-Eaton myasthenic syndrome. LEMS.
Right, LEMS. The problem here is also autoimmune, but the target is different. The autoantibodies attack presynaptic calcium channels on the nerve ending itself. This reduces the amount of acetylcholine that gets released from the nerve in the first place.
Okay, so in myasthenia, the problem is the muscle lock being blocked. But in Lambert-Eaton, it's a problem with the nerve key not delivering enough signal to begin with.
Precisely. The nerve isn't releasing enough of the chemical messenger, so the muscle doesn't get a strong enough signal to activate properly. Less signal sent.
Gotcha. A clinician shared a very insightful case about this. My patient's main complaint was leg weakness, especially trying to stand up from a chair. But strangely, he said after walking a bit, they'd feel a little stronger, not weaker. He also complained of constant dry mouth and constipation, some autonomic symptoms. The doctors were a bit puzzled at first, but then a lung scan showed a tumor small cell lung cancer. That's when they connected the dots to Lambert-Eaton syndrome, explaining that his immune system was attacking those nerve calcium channels. It was a paraneoplastic syndrome. Well, it was a strange revelation for him that his weakness was actually a sign of something much bigger, his cancer, and that trying to make his muscles work actually helped a little initially.
That case highlights the crucial differences perfectly. Unlike myasthenia gravis, where weakness typically worsens with activity, and Lambert-Eaton, the weakness paradoxically improves transiently with repeated muscle activity. That's key. And those autonomic symptoms, like dry mouth, are common in LEMS, but not typically in MG. But the absolutely key differentiating factor, and a huge exam pearl, is its very strong paraneoplastic association, especially with small cell lung cancer. LEMS is often the first clue that someone has this type of cancer.
Okay, let's pivot now. We're going to talk about a condition affecting pigmentation. Albinism.
Albinism. So this condition is characterized by a normal number of melanocytes. Those are the cells that produce pigment. But crucially, there is decreased production of melanin, which is the actual pigment itself.
Okay, so the pigment-producing factories, the melanocytes, are there in normal numbers, but they just can't make the color, the melanin.
Exactly. The machinery for color production isn't working properly due to various genetic defects affecting the melanin synthesis pathway.
Right. We got a submission from a listener that illustrates this really clearly. Growing up, I always looked different. My hair was white, my skin incredibly pale, and my eyes seemed to reflect light, oddly. This caused me to be really sensitive to bright light photophobia, they called it. And sometimes my eyes would even make involuntary rapid movements, which is nystagmus. The sun was my enemy. A few minutes outside without protection, and I'd burn instantly. My parents explained I had albinism, meaning my body couldn't make enough melanin, the protective pigment in skin, hair, and eyes. They taught me to wear hats, long sleeves, sunscreen religiously. The constant light sensitivity and vision issues are a real challenge.
Yes, and the key here is that despite having the normal number of pigment cells, their inability to produce sufficient melanin explains all those features. The characteristic light skin, hair, and eye color, the visual impairments like nystagmus and photophobia, and importantly, it explains the significantly increased risk of skin cancer because there's no natural melanin shield against UV radiation. It's a visible condition with really important hidden risks.
Okay, following albinism, here's another condition impacting skin color, but with a completely different mechanism, vitiligo.
Right, vitiligo. This is an autoimmune condition. Here, there is direct autoimmune destruction of melanocytes.
Ah, okay. So unlike albinism, where the cells are present but not producing pigment properly, in vitiligo, the actual pigment-producing cells are being destroyed by the body's own immune system.
That's the critical distinction, yes. Here, the immune system actively targets and eliminates the melanocytes themselves in certain areas.
Got it. This submission highlights that difference. It started as a small white spot on my hand, barely noticeable. Then, over a few months, more patches appeared on my face, my neck, my knees. It was like parts of my skin were just losing all their color in these distinct, sharp-edged patches, completely white. My dermatologist told me I had vitiligo, explaining it was an autoimmune condition where my body was literally attacking and destroying the cells that give skin its color. It's hard sometimes, especially when people stare, but I'm learning to embrace my unique skin. The distinct, completely depigmented patches really are its hallmark, aren't they?
They are. And what's fascinating here is that because vitiligo is an autoimmune attack destroying melanocytes, it leads to those very characteristic, well-demarcated patches of complete depigmentation. This autoimmune basis also means it's often strongly associated with other autoimmune conditions, like thyroid disorders, pernicious anemia, Addison's disease. So finding vitiligo isn't just about the skin. It's often a clue to check for potential broader immune system activity.
Now, let's explore a very, very common skin condition that affects so many people, atopic dermatitis. You probably know it as eczema.
Ah, yes, eczema. It's actually quite complex. It involves multiple factors all playing together. There's epidermal barrier dysfunction, meaning the skin's protective outer layer isn't working as well as it should. There are genetic factors like loss of function mutations in the filigran gene, which is important for that skin barrier. There's also immune dysregulation, an altered skin microbiome, the bacteria living on the skin, and various environmental triggers that all contribute to inflammation.
Wow, so it's like a perfect storm. The skin's protective shield is weak, maybe because of genetics, the immune system is overreacting, and then outside irritants just set it off. That sounds miserable.
It absolutely can be. It's like the skin's natural defenses are down, making it hypersensitive and prone to inflammation and intense itching.
Yeah, a parent emailed us a really heartbreaking story about their son. From the time he was a baby, my son Alex had this terrible itch. It was relentless. His skin would get red, dry, and scaly, especially in the creases of his elbows and knees as he got a bit older. He'd scratch so much, especially at night, that his skin would bleed and eventually get thick and leathery over time, what they call lichenification. His pediatrician said it was atopic dermatitis or eczema, explaining it was a problem with his skin's protective barrier and an overactive immune system. We're constantly moisturizing, trying different creams, and trying to figure out what triggers his flares, foods, soaps, stress. It's hard to know. It's just heartbreaking, especially at night when the itching keeps him and us awake. The relentless itching really defines it, doesn't it?
It really does. That intense itching, or pruritus, is indeed the cardinal symptom. Without the itch, it's probably not eczema. And if we connect this to the bigger picture, it often has that characteristic changing distribution with age. Typically on the extensor surfaces, like the outside of elbows and knees and the face in infants, and then it shifts more to the flexural surfaces, like the inside of elbows and knees, the wrists, ankles in older children and adults. And remember, it's often part of the atopic triad, frequently seen alongside asthma and allergic rhinitis. That personal or family history is a big clue.
Okay, from chronic eczema, let's look at an acute triggered skin reaction. Allergic contact dermatitis.
Right, allergic contact dermatitis. This is different from eczema. It's classic type IV hypersensitivity reaction. This means it's a delayed immune reaction, not an immediate one like, say, a bee sting allergy. During the initial exposure, the sensitization phase, an allergen like poison ivy oil activates specific immune cells, T helper 1 cells. These then form memory CD4 plus and CD8 plus T cells. Upon re-exposure to that same allergen, these memory cells get activated. The CD4 plus cells release inflammatory chemicals, cytokines, and the CD8 plus cells directly kill targeted skin cells, leading to the rash.
Okay, hold on. So your immune system basically remembers a substance it didn't like the first time, maybe weeks or years ago,
Yeah.
and then launches a delayed targeted attack when it encounters it again.
Precisely. It's a classic example of T-cell-mediated immune memory causing inflammation in the skin.
Got it. Here's a hiker's tale that perfectly illustrates this. After a long hike, I noticed a red, intensely itchy, blistering rash breaking out on my arms and legs. It was in streaks, like lines, exactly where my skin must have brushed against some plants. I remembered seeing some poison ivy along the trail, but didn't think I'd actually touched it. The doctor explained it was allergic contact dermatitis, a delayed reaction. My immune system had learned to recognize the urushiol oil from the plant, probably from a previous unnoticed exposure. This time, it mounted a full response. It took weeks for the blistering rash to finally go away, a constant, itchy reminder to be more careful.
That is textbook allergic contact dermatitis. It's a delayed type IV hypersensitivity reaction. The key features are it's delayed, appearing maybe 72 hours after exposure. It's intensely itchy, often with vesicles or blisters. And critically, the rash is always localized precisely to the area of contact and often has a very specific pattern reflecting that contact, like those telltale linear streaks from brushing against poison ivy. If the trigger isn't obvious, like poison ivy, patch testing is the gold standard for diagnosis. It involves applying small amounts of suspected allergens to the skin to see which one causes a delayed reaction.
Okay, let's shift now to a much more severe blistering skin condition, Pemphigus vulgaris.
Pemphigus vulgaris. Yes, this is serious. It's a type 2 hypersensitivity reaction. In this case, the body produces immunoglobulin G, or IgG, autoantibodies that form against proteins called desmoglein 1 and 3. These desmogleins are crucial components of desmosomes, which are like the spot welds or glue holding skin cells, the keratinocytes, together in the epidermis. When these antibodies attack, they cause the keratinocytes to separate from each other within the stratum spinosum, leading to blister formation.
So the immune system attacks the glue holding the skin cells together, causing them to fall apart and form blisters. That sounds awful.
It is. The blisters are typically fragile because the split is within the epidermis itself.
We received a harrowing account. It started with incredibly painful sores in my mouth that just wouldn't heal. Eating became a nightmare, just agonizing. Then these fragile blisters started appearing on my skin. They were so thin-walled, they'd pop if I just brushed against something lightly, leaving raw, painful, eroded areas. The dermatologist gently rubbed my apparently normal-looking skin nearby, and the top layer just peeled away easily. She called it a positive Nikolsky sign. A skin biopsy and blood test confirmed it was Pemphigus vulgaris, my body attacking the glue holding my skin cells together. It sounded like a really scary diagnosis.
Absolutely. And what's fascinating, clinically speaking, is that the autoantibodies attacking desmoglein 1 and 3 lead directly to those characteristic flaccid, easily ruptured blisters, often starting in the mouth. That positive Nikolsky sign, where lateral pressure on the skin causes blistering or erosion, is also a key finding. And the fact that oral involvement is very common and often the initial symptom is a major diagnostic clue distinguishing it from some other blistering diseases.
Now, following that, let's discuss a related but distinct blistering disorder, bullous pemphigoid.
Bullous pemphigoid. Also blistering disease, also autoimmune, and also a type 2 hypersensitivity reaction. But here the target is different. The IgG autoantibodies attack components of the hemidesmosomes. Hemidesmosomes are structures that anchor the bottom layer of epidermal cells, the stratum base cell, to the underlying dermis, the basement membrane. So the attack causes a separation between the entire epidermis and the dermis.
Okay, so Pemphigus vulgaris was skin cells separating from each other within the epidermis, but bullous pemphigoid is the whole top layer of skin separating from the layer underneath it.
Exactly. That difference in the level of the split explains the difference in the blisters.
Interesting. We got a story from a grandchild about their grandparent. My grandmother started getting these large, really itchy blisters on her arms and legs. Unlike the ones you just described, these were really tough, very tense, filled with fluid, and they didn't pop easily at all. The itching was maybe the worst part for her, drove her crazy. The doctor did a biopsy, and it turned out to be bullous pemphigoid. He explained that her immune system was attacking the anchors holding the top layer of her skin down, causing these big, strong bubbles. It was a lot to manage, especially with the intense itching, but knowing what it was helped them get the right treatment, mostly steroids. The itching sounds like a huge problem.
It often is. Pruritus is usually very intense in bullous pemphigoid. So this raises the important question. How does it differ clinically from Pemphigus vulgaris? Well, as the story highlights, in bullous pemphigoid, the antibodies attack hemidesomes, causing that deeper split. This results in tense, fluid-filled, difficult-to-rupture blisters. It also typically affects older patients, say, over 60 or 70. And unlike pemphigus, significant oral involvement is much less common, and the Nikolsky sign is usually negative because the epidermis itself is intact. Those are key differentiating points.
Okay, fascinating distinctions. Let's transition now to developmental anomalies, starting with the spectrum of spinal dysgraphism. Spina bifida occulta, meningocele, myelomeningocele, and myeloschisis.
Right, this group of conditions results from a failure of the neural tube to close properly during early embryonic development. Specifically, it's the failure of the caudal neuropore, the tail end of the developing neural tube, to fuse by the 4th week of development.
The 4th week, that's incredibly early in pregnancy.
It is a critical window.
A listener shared two very different experiences within the spectrum. When my daughter Sarah was born, the doctors pointed out a small tuft of hair and a little dimple on her lower back. They diagnosed it as spina bifida occulta, a mild, usually harmless form where the defect is covered by skin. Quote, "We were relieved it wasn't more serious, but the pediatrician stressed the importance of taking folic acid supplements before and during any future pregnancies." Years later, a friend's baby was born with myelomeningocele. It was much more severe, a visible sac protruding from his back containing spinal cord tissue and nerves. He had significant weakness in his legs and bowel bladder issues from birth. It was heartbreaking, and they talked constantly about how crucial early folic acid supplementation is, ideally preconception, as it could have potentially prevented it. It's such a stark reminder of those critical early weeks of development.
Absolutely. The key takeaway is that all these forms, from the hidden occulta to the severe open defects like myelomeningocele and myeloschisis, result from that failure of the caudal neuropore to fuse during the 4th week. Myelomeningocele, where the spinal cord itself protrudes, is the most common severe form and almost always associated with other neurological issues, particularly the Chiari II malformation and hydrocephalus, which we might touch on later. And as the story highlights, folic acid supplementation before conception and during the first trimester is the single most important preventive measure, dramatically reducing the risk.
Okay, from the caudal or tail end, neuropore, let's move to a severe defect at the other end, the rostral end, an encephaly.
Encephaly. This is also a neural tube defect, but it involves the rostral or head end. The mechanism is the failure of the rostral neuropore to close, typically around day 25 of gestation. This catastrophic failure leads to the absence of the forebrain and an open calvarium, meaning the skull doesn't form properly over the rudimentary brain tissue.
Absence of the forebrain, that sounds devastating.
It is incompatible with life beyond a very short period.
We received a story about a devastating prenatal diagnosis. It was during our 20-week ultrasound that the room went silent. Our baby had an encephaly. They gently explained that a large part of her brain and skull hadn't formed properly, and that tragically she wouldn't be able to survive after birth. We learned it was a neural tube defect. Although I had been taking prenatal vitamins, the doctor emphasized how vital folic acid is, even before conception, to help prevent such tragedies. Quote, "We chose to carry her to term, and we held her for a short time after she was born, cherishing every fleeting moment." It just underscores the immense importance of that very early brain development.
It really does. And this raises the important question, why is it so severe? Because it's the failure of the rostral neuropore to close, resulting in the absence of the forebrain, the cerebrum, and an open skull. It's incompatible with sustained life after birth. And again, like other neural tube defects, adequate maternal folic acid intake before and during early pregnancy is the key known preventive measure.
Next, let's discuss another brain malformation, one that impacts how the brain divides. Holoprosencephaly.
Holoprosencephaly. This results from a failure of the embryonic forebrain, the prosencephalon, to divide properly into two cerebral hemispheres. It's considered a developmental field defect, typically occurring very early, around weeks 3 to 4 of development. It's often associated with genetic factors, including mutations in genes like sonic hedgehog, SHH, which plays a critical role in brain patterning.
Failure to divide into two halves, so the brain remains sort of one whole structure instead of two distinct sides.
Essentially, yes, to varying degrees. It's a spectrum from severe forms where there's almost no division to milder forms.
Another ultrasound story highlighting this. When they showed us the ultrasound of our baby, they pointed out something wrong with the brain structure. The doctor gently explained that it looked like holoprosencephaly, meaning her forebrain hadn't divided into two halves like it should have during early development. Quote, He showed us how severe it appeared and also pointed out some associated facial features, like eyes being closer together than normal and a cleft lip. Quote, "It was overwhelming. We later learned through genetic testing it was linked to a chromosomal abnormality, trisomy 13. Quote, "We braced ourselves for a difficult journey, understanding that her life would be profoundly impacted by the severe brain malformation." It's another stark reminder of how intricate early development is.
It is. And what's fascinating and diagnostically helpful is that this incomplete division of the forebrain often comes with characteristic midline facial anomalies. These can range from severe things like cyclopia, a single eye, or proboscis, to more common findings like hypotelorism, eyes being too close together, or a midline cleft lip and palate. The severity of the facial defects often mirrors the severity of the brain malformation. And as this story mentioned, there's a strong association with certain genetic syndromes, particularly Pat-Howe syndrome, which is trisomy 13.
Now let's talk about a condition where the brain's surface is abnormally smooth, lissencephaly.
Lissencephaly literally means smooth brain. The mechanism is a failure of neuronal migration during fetal development. Normally, newly formed neurons migrate outwards from near the ventricles to form the layers of the cerebral cortex, creating the characteristic folds, Chiari, and grooves, sulci. In lissencephaly, this migration process is disrupted, leading to a brain surface that lacks those normal convolutions, appearing smooth or having very few broad Chiari.
So the brain cells don't travel to their proper destinations, leaving the surface smooth instead of wrinkled.
Exactly. The complex architecture of the cortex fails to develop.
A parent shared this about their child, Leo. "Our little one, Leo, just wasn't reaching any of his developmental milestones. He had trouble feeding from the start, poor muscle tone. And then he started having these strange, brief seizures, like sudden body jerks or spasms, hundreds a day sometimes. The doctors ordered an MRI of his brain, and that's when they showed us the images. His brain was almost completely smooth, without the normal folds and grooves. They call it lissencephaly, explaining it was because his brain cells hadn't migrated to the right places when he was developing in the womb. Quote, "It was a devastating diagnosis, understanding he would face profound developmental delays and likely intractable seizures." The image of a smooth brain is just so striking and explains so much.
It really is. The key imaging finding here is that smooth brain surface, also called ageria, no Chiari, or pachygeria, broad Chiari. It's caused by that failure of neuronal migration, which directly leads to severe intellectual disability, developmental delay, and often those very difficult to control seizures, like the infantile spasms described. There are several genetic causes linked to lissencephaly.
Okay, from brain structure defects, let's look at the Chiari malformations, starting with Chiari I.
Right, the Chiari malformations involve the cerebellum, the part of the brain at the back involved in coordination and balance. In a Chiari malformation, the mechanism is the downward displacement of the cerebellar tonsils. Those are the lowermost lobes of the cerebellum, through the foramen magnum, the large opening at the base of the skull where the spinal cord exits. So part of the cerebellum is sitting lower than it should, extending down into the spinal canal.
Just slipping down a bit too far.
Essentially, yes. Usually just the tonsils, and typically acquired or presenting later in life, often adolescence or adulthood.
We heard about a listener's long journey to diagnosis. "For years, I'd had these terrible headaches. They always started at the back of my head and radiated down my neck. They were always worse when I coughed or sneezed or strained any kind of Valsalva maneuver. It would make me feel dizzy, too. It wasn't until I started having some unsteadiness on my feet and tingling in my hands that my doctor finally ordered an MRI of my brain and neck. That's when they found it a Chiari malformation. My cerebellar tonsils were dipping several millimeters below the base of my skull. It was actually a relief to finally have an answer for years of these puzzling symptoms. That worsening with coughing or straining sounds like a key clue."
It absolutely is. The characteristic symptom is often those occipital headaches, pain in the back of the head, that are clearly exacerbated by Valsalva maneuvers like coughing, sneezing, or straining. That's because those activities temporarily increase pressure and crowd the already tight space at the foramen magnum. Chiari either also has a very strong association with syringomyelia, which is a fluid-filled cyst, or syrinx, developing within the spinal cord itself, often causing sensory or motor symptoms in the arms and hands. Finding one often prompts looking for the other.
Okay, now for the more severe form, Chiari II malformation.
Chiari II is different and more complex than Chiari II. The mechanism here involves herniation not just as the cerebellar tonsils, but also the cerebellar vulgaris, the central part of the cerebellum, and parts of the brainstem, specifically the medulla, down through the foramen magnum. The significant downward displacement almost always obstructs the flow of cerebrospinal fluid, CSF, causing non-communicating hydrocephalus, a buildup of fluid pressure within the brain.
So much more tissue is pushed down, and it actually blocks the fluid flow in the brain.
Exactly. It's a more extensive herniation with more severe consequences, usually present at birth.
A parent shared their experience. From the moment she was born, we knew something wasn't right with our daughter. She had difficulty breathing, especially inhaling, making a high-pitched, noisy sound called stridor.
Hmm.
The doctors quickly found a large myelomeningocele on her back, that open spinal defect we talked about earlier. Okay. An MRI then revealed she also had a Chiari II malformation. Her cerebellum and part of her brainstem were pushed way down into a spinal canal. Oh, quote, this was blocking the fluid flow in her brain, causing hydrocephalus, which required a shunt. It was terrifying to see her struggling with every breath due to the brainstem compression. They faced many surgeries right from the start.
That's a very typical presentation for Chiari II. What's fascinating and critical to understand is that Chiari II involves a more extensive herniation vermis, tonsils, and medulla. It almost invariably causes non-communicating hydrocephalus requiring treatment, often a shunt. And crucially, it is very, very strongly associated with myelomeningocele. Essentially, all patients with myelomeningocele have a Chiari II malformation. It often presents at birth or in early infancy with symptoms related to that brainstem compression, like swallowing difficulties or breathing problems as described.
Let's explore another malformation involving the back of the brain, the posterior fossa, Dandy-Walker malformation.
Dandy-Walker malformation. This involves specific developmental issues within the posterior fossa itself. The core mechanism is agenesis, or failure of formation, of the cerebellar vermis, that central part of the cerebellum. This lack of the vermis allows the fourth ventricle, a fluid-filled space in that area, to become cystically enlarged. This enlarged ventricle then fills up most of the posterior fossa, which itself is often enlarged. It's frequently associated with non-communicating hydrocephalus and sometimes spina bifida as well.
So a key part of the cerebellum is missing, and the fluid space behind it gets really big.
That's the essence of it, yes. Agenesis of the vermis leading to a cystic fourth ventricle filling an enlarged posterior fossa.
A parent told us this story about their baby, Maya. When Maya was a few months old, we noticed her head circumference was growing much faster than expected on the growth charts. She also seemed to have trouble holding her head steady, seemed very floppy, and was delayed in her motor skills. The doctors ordered an MRI, which revealed the Dandy-Walker malformation. They explained that a key part of her cerebellum, the vermis, hadn't formed properly, and the fluid-filled space in her brain, the fourth ventricle, was hugely enlarged, taking up most of the space at the back of her head. Quote, it was overwhelming news, but the clarity of the diagnosis on the MRI helped us understand the reasons for her developmental challenges and the need to monitor for hydrocephalus. It sounds like a truly striking imaging finding.
It is usually very clear on imaging. The key diagnostic features for Dandy-Walker are that triad. 1, complete or partial agenesis of the cerebellar vermis. 2, that large cystic enlargement of the fourth ventricle. And 3, an enlarged posterior fossa. And as mentioned, it's commonly associated with hydrocephalus, often requiring shunting, and sometimes other congenital anomalies like spina bifida or heart defects.
Now, let's look at a condition within the spinal cord itself, often linked to Chiari the syringomyelia.
Syringomyelia. This refers to the development of a fluid-filled, gliosis-lined cavity, basically a cyst called a syrinx within the central canal of the spinal cord. It's most commonly associated with Chiari I malformation. The thinking is that the low-lying cerebellar tonsils disrupt normal CSF flow dynamics at the base of the skull, forcing fluid down into the central canal of the cord. Less commonly, it can be associated with spinal cord infections, tumors, or trauma. Critically, as the syrinx expands, it damages surrounding nerve tracts, particularly the crossing fibers of the spinothalamic tract.
Okay, so a fluid cyst forms inside the spinal cord, often because of that Chiari I issue, and it damages nearby nerve pathways.
Precisely. Especially those fibers carrying pain and temperature information that cross near the center of the cord.
This patient's experience is quite unique and highlights that specific damage. I started noticing really weird things, like I'd burn my hand on the stove or spill hot coffee on my arm and barely feel the heat or pain, even though I could still feel the pressure of the cup. It was like half of my sensations were just missing, especially across my shoulders and upper back, sort of like wearing a cape. My hands also started feeling weaker over time, and I was losing fine motor control. After an MRI of my spine, the doctor showed me this long, fluid-filled cavity within my spinal cord, a syrinx. They explained it was likely caused by a Chiari I malformation they also found, and that the syrinx was damaging the specific nerves for pain and temperature in that area. It must have been so unsettling to lose those protective sensations.
Definitely. And this raises the important question, why that specific pattern of sensory loss? It's because that expanding fluid-filled cavity, the syrinx, typically starts centrally and damages the crossing spinothalamic tract fibers first. These fibers carry pain and temperature sensation from the arms and upper trunk. This leads to that classic cape-like distribution of loss of pain and temperature sensation across the upper back, shoulders, and arms, often with preserved light touch, vibration, and position sense initially as those tracts run elsewhere in the cord. Recognizing that dissociated sensory loss pattern is key, and the strong association with Chiari malformation is vital. Always look for a syrinx if you find Chiari I and vice versa.
Okay, let's move into syndromes affecting specific brain functions now, starting with Gerstmann syndrome.
Gerstmann syndrome. This is a very specific neurological syndrome caused by damage to a particular part of the brain. The mechanism is a lesion, often a stroke or tumor, in the dominant parietal cortex, specifically the angular gyrus area. For most right-handed people, this is the left parietal lobe. Damage here causes a characteristic cluster of 4 deficits: agraphia, acalculia, finger agnosia, and left-right disorientation.
Oh, okay. Dominant parietal cortex, and that causes agraphia, acalculia, finger agnosia, and left-right confusion. Can you break those down?
Sure. Agraphia is the inability to write. Acalculia is the inability to perform calculations. Finger agnosia is the inability to identify your own or someone else's fingers by name. And left-right disorientation is trouble distinguishing left from right.
Got it. A family member shared this about their grandfather. My grandfather started acting really strangely after what we later learned was a small stroke. Quote, he'd try to write a simple shopping list but would get stuck, completely unable to form the words on paper, even though he could speak fine. Then, he couldn't figure out how much change he should get at the store. Simple addition was impossible for him. He'd also do odd things like point to his thumb and call it his index finger, and he constantly mixed up left and right directions. Quote, the doctors explained he had Gerstmann syndrome due to the stroke damage in that specific part of his left parietal brain. It was heartbreaking for them to see such fundamental abilities just vanish like that.
It's a striking syndrome. And what's fascinating neurologically is how damage to that specific area, the dominant angular gyrus, leads to that classic tetrad: agraphia, acalculia, finger agnosia, and left-right disorientation. Recognizing all 4 of these deficits together strongly points towards a lesion in that particular location. It's a very localized finding.
Okay, from Gerstmann, let's discuss a similar yet distinct syndrome involving spatial awareness. Hemispatial neglect syndrome, sometimes called contralateral neglect.
Yes, hemispatial neglect. This is also typically caused by a lesion in the parietal cortex, but usually in the non-dominant hemisphere, which for most people is the right parietal lobe. The mechanism involves damage here leading to agnosia, or an inability to perceive or tend to stimuli, on the contralateral side of space, usually the left side. It's not a vision problem, it's an attention or awareness problem.
So damage to the right side of the brain causes someone to basically ignore the left side of their world, even if they can technically see it.
Exactly. Their brain fails to process or attend to anything on that left side.
A listener shared this about their aunt after she had a stroke. After her stroke, my aunt started doing really peculiar things. She would only eat food from the right side of her plate, leaving the entire left side completely untouched, as if it wasn't there. When she tried to put on makeup, she only did the right side of her face. She'd draw only the right half of the clock. She'd constantly bump into door frames or furniture on her left side, completely oblivious. And the strangest part was, she genuinely didn't seem to notice anything was amiss. She wasn't aware she was ignoring her left side. The doctors explained it was hemispatial neglect caused by the damage to the right side of her brain. Her brain was literally ignoring the left half of her universe. It sounds like a really bizarre and challenging condition to manage.
It is. And if we connect this to the bigger picture, it's crucial to understand it's typically a lesion in the non-dominant, usually right parietal cortex, causing that unawareness or neglect of the contralateral, usually left side of space, even though primary vision is intact. The absolute key feature, as highlighted in the story, is that patients are often completely unaware of their own deficit, a condition called anosognosia. They don't realize they're neglecting anything. This makes it very distinct from simply having a visual field cut, like hemianopia, where the patient knows they can't see on one side. The lack of awareness is central to neglect.
Wow, that lack of awareness is profound.
Mm-hmm.
Okay, our final deep dive for today takes us to a really striking behavioral syndrome, Kluver-Bucy syndrome.
Kluver-Bucy syndrome. This is a rare but dramatic behavioral syndrome. The mechanism involves bilateral lesions damage on both sides affecting the amygdala, which are structures deep within the temporal lobes critical for processing emotions, particularly fear and regulating behavior. It's most classically seen after infections that affect these areas, particularly HSV-1 encephalitis, though it can occur from other causes like stroke or trauma affecting both amygdalae. The damage leads to profound disinhibition and a cluster of behavioral changes, often summarized by hyperphagia, hypersexuality, and hyperorality.
Bilateral amygdala damage, so damage to the emotion centers on both sides of the brain, leading to hyperphagia, hypersexuality, hyperorality. What do those mean?
Right. Hyperphagia means excessive eating, often indiscriminate eating, including non-food items. Hypersexuality refers to inappropriate or excessive sexual behaviors, and hyperorality is a compulsion to put objects, including inedible ones, into the mouth. There's also often profound placidity or loss of fear and visual agnosia difficulty recognizing objects.
That sounds incredibly disruptive and disturbing.
It is a complete change in personality and behavior.
We received a chilling account from a caregiver. After recovering from a severe bout of encephalitis, which turned out to be caused by the herpes simplex virus, HSV-1, my relative's personality completely changed. Quote, she became overly friendly to strangers, lacked any social filter, constantly saying inappropriate things without seeming to realize it. She started eating constantly, anything she could find, even trying to eat non-food items off the table. And she developed this strange habit of putting everything she picked up, keys, remote controls, anything, straight into her mouth. Quote, she also seemed unusually calm, almost fearless, in situations that would normally scare someone. It was shocking and heartbreaking to witness. End quote. The doctors eventually explained that the HSV-1 infection had severely damaged both of her amygdalae, leading to Kluver-Bucy syndrome. It was such a stark reminder of how specific brain damage can fundamentally alter a person's entire behavior and personality.
It truly is. And this raises the important question: what causes these extreme, almost primal behavioral changes? It's that bilateral damage to the amygdalae, the brain's fear and emotional processing centers. Losing that control unleashes these behaviors. As mentioned, it's most commonly seen after HSV-1 encephalitis, which has a predilection for the temporal lobes where the amygdalae reside. The key features to remember, sometimes called the 4 H's plus placidity, are that hyperphagia, hypersexuality, hyperorality, and general disinhibition or hyperdocility, loss of fear aggression. It vividly illustrates the amygdala's crucial role in regulating emotion, fear, and social behavior.
Wow, what a journey through some truly complex and, frankly, fascinating conditions. From the subtle immune attacks of Sjögren's all the way to the profound neurological shifts of Kluver-Bucy syndrome. We covered 22 conditions today, each with its unique mechanism and, as we heard, its very real-world impact. Our goal was really to make these facts stick, to give you that aha moment by connecting the science to the human experience through those stories.
Indeed. And I think each story revealed not just symptoms, but hopefully a deeper understanding of how our body's incredibly intricate systems can sometimes go awry. It really highlights the importance of recognizing patterns, of thinking critically about the underlying why behind symptoms. Because truly being well-informed, whether you're a patient, caregiver, student, or just curious, isn't just about knowing the facts. It's about understanding their profound implications. Maybe as you go about your day, you might consider which of these mechanisms could be at play around you, the hidden processes shaping our health and the health of those we know.
Absolutely. A great thought to end on. We really hope this deep dive has given you a shortcut to being better informed, maybe sparked some curiosity, and perhaps inspired you to keep digging into the incredible complexities of the human body. If you have sources, maybe clinical cases or research papers you'd like us to dive into for a future session, please do send them our way. Until next time, keep being curious and keep asking why.